Hello and welcome to the Auditing Antics Podcast. So, we're happy to be back. Michelle had a fun weekend. She came up here to Knoxville and got to hang out with me and my family. We had big milestone. Our grandson turned 1. So Michelle came and celebrated that with us. If you saw my post on LinkedIn, he is actually my birthday twin. So that's always fun. Happy to let him have that day and celebrate and you know all the fun things. So all right, now this week we're going to be talking about the global surgical package, and really more so I equate this to medical necessity and how we break that down. And Michelle, I know a lot of the times when we're doing our audits and feedback and education, all of that, one of the things that's really difficult is people do not always understand what that looks like prior to surgery, right?
Yeah.
If we look this up from like a CPT perspective and some of the guidelines, there's always reference to a 24-hour period, but in actuality, that's not really how it works. And, I find that that is really a big driver of a lot of variances when we're looking at services that have that global package.
hmm Yeah, I think that it can be really confusing to break down when can you bill, who can bill, and it can just be a lot of confusion. And oftentimes, I think we do find where there are some misunderstandings as it relates to what is billable in that global period.
Mhm. And to break this down, I think it'll be good to just take a step back and talk a little bit about what the global periods are and where we can get some more data if we have to have these conversations with our surgeons and sometimes even with their APP staff, because there are times where they're doing work that's not billable and or separately billable, and depending on the structure of the practice and things like that, they'll look at that as a negative. So we really need to understand the basics to know why we have the global periods and how that's broken out.
Yeah.
So one of the main things I like to do, the encoder program I use is Codify from AAPC, and I rely on that quite a bit because you can go into your CPT codes and look at the fee schedules, and it's going to show you the global period, but you can also look at things like the breakout of the RVUs. You can even go into the CMS website. They have a physician fee schedule lookup tool,
hmm
it's called. You can look up the CPT codes and find the breakout. And Michelle, one of the things that I thought was interesting, I had a conversation with a client years ago, and they were the ones who pointed to this particular data. When you're looking at these surgical codes, you'll see that there's an allocation for a percentage of just the surgery payment that is for preoperative work, intraoperative work, and postoperative work. So
Yes.
I personally like to show that if I'm being met with a lot of frustration, I like to go down to that main source to say, "Hey, this is how these codes are paid out. Yes, it's paid based on the surgery you're performing, but wrapped up inside that are all of these other things that go along with it."
Yes, yes. And I think a lot of times that's not where the focus is placed. They think, oh, that's just what I get paid for the performance of this particular surgery or procedure. But it's not. There's actually a breakdown of each individual piece that goes along with that. So I think that was a really good point to make and a good resource to familiarize yourself with if you're not. If you're somebody who finds yourself having this conversation a lot, go out there and find that physician fee schedule and just start looking things up and taking a look at what that information looks like. It's always good to have like something in writing to take
Yes,
with
yes,
you and not just
exactly.
because I said so.
Yes, exactly. Well, and one of the biggest things that I get pushback on is the preoperative period. And we have to remember that with everything that we're doing in compliance as it relates to coding and billing and documentation, we have to look at that big subjective concept of medical necessity.
hmm
So we could get asked about the 24-hour period, but in actuality, if you have someone who sees a patient, they decide on surgery today and surgery's not for another month, then if that patient comes in within that time period of a month, unless there's something new that has to be addressed with a different treatment plan, that's included and it's still not going to be separately reportable, even if it's weeks out, days out, whatever it may be from that surgery.
And I think that's one that I see most often are
Mhm.
those preoperative exams. And I think this is an instance where we see those APP providers being used where that conversation might need to be had where the work of that encounter is considered inclusive to
Mhm.
that global surgical package. So it's definitely something that I think people need to take a look at are those preoperative visits. You have to go back and look and see, has the decision for surgery already been made? And a lot of times, yes, it has been. This is not the encounter where they're making that decision. So it's really something that I think is the most commonly misbilled visit as part of that global surgical package.
Mhm. And I've had situations too where we talk about it and break it down, or I have concerns about the way they're handling it. And I look back in the system, and you can see, for example, that they will meet with, say, a PA that works with the surgeon or an NP. And then all of the sudden, what ends up happening is they're having a discussion with the patient. They're saying that, okay, it probably is time for surgery, but because they are given the task of things like patient education, getting post-op things ordered, all of that, they'll go through the whole thing at that point and talk through patient consent. They'll talk through the plan. And it essentially makes it look like the PA or the NP made the decision for surgery. And when I've looked in the background, I've found sometimes that at that point, the surgery is also scheduled.
hmm
So if that's a workflow, that's not going to work with compliance for coding and billing, because when that patient then comes back to see the actual surgeon, it looks like that's a preoperative clearance exam. And it doesn't look like that was the day of decision and all of those main points of that, really, that last time that you can bill for prior to surgery, unless something new comes up.
Yeah, and I really would have to think what is the medical necessity behind them seeing the PA and then
Hmm.
essentially having the same exact visit with with the MD.
Wait, wait, or they'll copy and paste.
Yes, that's they do. I have seen that.
They'll
Um,
bring the APP's note forward and then be like, "Well, why can't I? These are my decisions." Well, it doesn't
yeah.
look like it.
Or I need to see the patient before the surgery. I've had that one before, and it's like, well, clearly the decision for surgery has already been made. And
Mhm,
you know, it's just one of those situations where I really have to wonder how that workflow is beneficial to the patient. Like,
mhm,
um, is it really necessary for them to be seeing all these people just because the physician doesn't want to do education, for example, and things like that? So I don't know. It's just kind of odd to me. If I were the patient, I'd be like, so I've already, you've already said you've scheduled me for this. Why do I need to,
mhm,
pay to come back again? And essentially, that's what the global surgical package is intended to prevent, um, in my opinion, is all those extra payments and things like that for the patient because it's already rolled in
mhm.
into the cost of the surgery.
Yeah, it's already allocated. And, when things like this come up, or if you start to have questions, if you're coding, if you're auditing, this is the time where you need to pause and talk more at an operational level too. So you may need to go back to the practice administrator and say, hey, what does scheduling look like for surgeries? Um, I have found too that if I'm auditing an NP or a PA and something like this is going on, we'll uncover a lot of workflow issues in that audit review as well. So there's
Mhm.
a lot of ways you can find it, but you have to remember it's not just a matter of, okay, this is preoperative. We have to always look outside of that box and make sure we understand what's going on and make sure everyone understands why we have different rules in place. Now, I do want to cover quickly, there could be times when the patient may have a big lapse in I don't want to say care, but maybe follow up, for example. So there's definitely been times where we've seen records where patients need a surgery, but maybe medically they're not stable enough. Maybe they have other things going on. Maybe they need to quit smoking, lose some weight. You all of those different things that could come up as a medical complication or raise their personal risk. If that's happening, or if the patient says, okay, yes, I would like to get my right knee replaced, but throughout the whole summer, I have all these vacations. Could I plan to do it at the end of the year so it's closer to the downtime at the holidays? Things like that, again, it's going to be very subjective. It's going to depend on the situation, what we can see in the note. But if they're having to reevaluate to see where that patient is many, many months later because things were essentially paused, that's
Mhm.
not what we're talking about here.
No.
That's different.
I wouldn't consider that to be the decision for surgery.
Hmm.
That's this is the option that they're saying is for this patient going forward,
Hmm.
certainly, but I wouldn't say that that's when the decision for surgery is made, especially if, like you said, I think we see a lot, um, the smoking cessation,
Yeah.
especially, or the weight loss, like you mentioned. So those are things that don't happen overnight. And yeah, that was a really good point to bring up. There's one more scenario kind of related to that preoperative visit that I think we see a lot, and that is patients being referred for colonoscopies. That
Mm-hmm.
is that's
This
kind of
is a
one of
hard
those
one.
pre preoperative visits that we're seeing, and it's kind of an interesting one because a colonoscopy doesn't have any global days associated with it.
Yes. Yes.
But is it really medically necessary for that provider to see the patient when it's already known that the patient is in need of a colonoscopy? So what are your thoughts on that, Stephanie, and how do you kind of work through that with your different clients as you come across those situations?
So, one thing I want to clarify with what Michelle's talking about, this is when the patients need a screening colonoscopy.
Yes,
So,
screening.
if there is a medical issue, a known condition, symptoms, all of those things, that could have that examination prior and bill for that outside of the pre op, all of that. Now, I do have to say, I understand the frustration from our physicians and providers in this particular realm because GI or general surgery, whoever's doing it, is singled out in this way where they're specifically told, oh, you can't do that because you're just doing a screening. But I've had many conversations, and remember, I always say it is so important to listen to our physicians and providers and hear their side of it, right?
Hmm.
And when you start to think about the risk that they take on their shoulders just by performing procedures, they have the legal risk, the potential malpractice, all of those things. In their mind, why would they ever feel comfortable just stepping in and saying hi to a patient during an H&P prior to a procedure and that's it? So this is one of those things that's difficult because CMS is the one who says that they're not going to pay for an E&M prior to a screening colonoscopy. Some
Hmm.
payers could follow along. Again, that's something you'd have to look into based on your network, who you participate with on the commercial side. But I know a lot of physicians who still choose to have the workflow of the patient coming in, and then they just don't bill for it because clinically they do not have a comfort level by just showing up at, the hospital and getting ready to go in and do a scope without really knowing anything about the patient. So,
Mhm.
yes, that one is difficult because those particular procedures are singled out, but unfortunately, that is how it works. So we have to make sure that we're sticking to the guidelines and then making sure our practices and facilities understand what that means for revenue if they choose
Mhm.
to still go forward with that workflow.
Yeah, and I think it's another opportunity to show our providers how billing guidelines don't dictate clinical
Hmm.
workflows for them. It's unfortunate when they don't line up in these instances, but just because you can't bill for something doesn't mean that it should dictate your clinical
Hmm.
workflow that you have in
Yes.
place.
Yeah, I've actually had some people who say, "So you're telling me I can't see the patient if I say something's inclusive?" And it's like, "No, no, no. That is not what we're talking about here. You have to do what you need to do clinically. Then we apply the coding and billing guidelines as appropriate. But we're not saying no, don't see the patient and just do these things, especially if you feel it's a clinical risk.
Mhm.
That's a decision that still has to be made, but not made by us."
Yeah, correct. And I think that the global surgical package is just one of those instances where they don't always the clinical and the billing don't always come together
Mhm.
quite how we like them to.
Yeah. Now, another area that can be confusing is when all of this ends up in the hospital situation. So, what we were talking about was specific more to elective surgeries, right?
Mhm.
Patients are being seen in an office setting. They're talking about what's appropriate for them. They're making an informed decision to move forward with it. It's then scheduled, it's not emergent. That is an elective surgery. So, when we look at situations of patients coming in through the ER, for example, that's going to look a little different because that is a known problem at that point. It's not like what we talked about with GI or general surgery, it's a screening. It's a known problem at that point. They're being
Mhm.
evaluated and they're determining whether or not that patient can wait for elective outpatient surgery. And in a lot of times, they can't. They need to be seen,
Mhm.
they need to have the surgery done right away or as soon as possible. So that situation, we are going to be able to bill for that E&M essentially as a consult, even
Mhm.
though consult codes are pretty much no longer reimbursed. So our initial
Initial visit.
hospital, yes, yes, our initial visit is going to have medical necessity at that point, but then, Michelle, I find we have this whole other tangled web in the postoperative period when it's a situation that that patient is now continuing a hospital stay. So they're
Mhm.
not having surgery and going home that day or the next day. They've had other things going on, or they require additional monitoring after. And that can be just as confusing when we have all of these different departments who are now coming in and seeing the patient.
Correct. And I think one of the most common things or something that gets a little confusing for me even as I'm auditing is when the surgeon comes in, performs the surgery, and then they transfer the care to, let's say, internal medicine, for
Mhm.
example. And internal medicine, when you look at it, is essentially just providing post-operative care. There doesn't seem to be any underlying conditions that they're treating. So how often would you say that you see those circumstances, Stephanie? I think it's something that I've been dealing with
Quite a
quite a
bit.
bit recently, actually, where they transfer the care after surgery, and then because it's a different specialty, it gets billed. And I would have to say medical necessity isn't always supported, even
Yeah.
under a different specialty. You have to think about, you know, what care is being provided, and if there isn't treatment of something that's not related to that surgery, like if they're just there and they're managing pain, for example, um something like that, that's considered post-op management. And whether it's the same specialty or a different specialty, that could be included in that global surgical package.
Well, and this is where it becomes difficult because sometimes organizations make that decision because they know the surgeon is not going to be reimbursed for that. Now,
Yes.
one thing I will say when I'm auditing, it is something that I will allow if I can see the work of that other department, we'll call it. So let's say
Hmm.
hospitalists. But a lot of times I have issues because I can't see the work. So if it's a
Yeah.
situation where the surgeon has signed off to the hospitalist group, or if the surgeon is still providing post op, but hospitalists come in every day and say, patient's doing fine, continue home medication, which they continued as soon as the patient got there, we still have this cloudy view. We don't really understand what's happening, what's new, and the individual decisions they're making.
Hmm.
So I do find that it can be questionable when hospitals make the decision to change workflow for revenue purposes.
Hmm.
That could be questionable. But a lot of times I also find that if I see that it's not supported by a hospitalist, it's deficient documentation. If
Hmm.
I talk with them verbally, they'll tell me all of these things they're worried about for the patient based on the type of surgery, all of those things. We have the same situation. There is protocol in place for a lot of specialty surgeons, for example, with spine surgery.
Hmm.
Usually, surgeons will not let a patient go home same day. They've got to
Mm-mm.
stay at least one night and they've got to stay in an ICU unit because that has more intensive monitoring. So, same with different cardiac surgeries, things like that. It's protocol that the patient not only stay, but then go into an ICU unit. So, this, I think, really goes back to the basics that we don't have automatic medical necessity based on, a location in the hospital or a
Or a protocol.
diagnosis or a protocol, right? We've got to see what the separation is. If
Mhm.
that surgeon is the one who's following up with the patient in critical care, meaning they're just physically in a critical care unit, but they didn't require critical care services, we're still inside of that global period. We don't have anything that's extra that they're going to be able to report, even though that surgery is of a higher risk than a patient who can go home same day.
Mhm. Correct. And I think you really hit the nail on the head when you said a lot of times these come down to documentation deficiencies, especially in the other specialties that isn't
Mhm.
the surgical specialty in particular. A lot of times, we just see them um, continuing the treatment that was laid out by the surgeon, for example, when really there were other things that they had been doing. So I think it's an
Mhm.
education opportunity to take that to your providers and, like you said, have a conversation with them, and then you see behind the scenes all of these other things that they were watching or working on or making the decisions about themselves. And
Mhm.
it's important that they show that work in their note. And most of the time, I think it's safe in saying most of the time that just is not present.
No, it's not. And, we have to remember in order to go out of that global period in a hospital situation where the patient's being seen subsequent, even for a discharge, all of that, we have to see what's unrelated to that surgery. So, like you had mentioned, Michelle, the post-operative pain management, things like that. That is related to the surgery. So, is it the surgical group? Is it someone else? Are they showing the work that's being done? If there's underlying conditions, how did it impact the need for additional management apart from regular routine post-operative care?
Mhm.
So, even if I look at something and it says the patient has three or four other unrelated chronic conditions, we still cannot automatically go to billing that with a 24 modifier. We've got to see all of this narrative in this other work. And
Mhm.
lastly, Michelle, one of the things that I find too is that it's hard for our providers to really grasp this as well, especially when we do have a hospital stay, because they are still having to go and see them daily typically.
Mhm.
Um, Depending on who's involved in that hospital stay, they're having to do an entire discharge summary, coordinate the care for afterwards. It's not the same as elective, outpatient surgery where the patient goes home and follows up in a week or whatever it may be.
Yeah.
So there is a lot of additional clinical work involved, but either way, it still does not open that up most of the time to be billing for that separately.
Mhm. Yeah, I agree.
All right. Now, I just want to give one last reminder. So, we are one day before the telehealth event that Terry Fletcher and I have tomorrow. So, tomorrow, which is Thursday, September 18th at 10 a.m. Eastern, we're going to be doing a telehealth webinar event. You can go to my website. It's here on the screen if you're watching, stephanieallardconsulting.com. I have a link to the event on the homepage there, and you can go to Eventbrite to purchase the ticket for that. We're basically going to be taking an hour and a half and really deep diving into telehealth, where it's at now, what the flexibilities are that are looking like they're going to expire. We were still digging in, and there's no new information yet. We're looking every day. It can definitely change. But we've got multiple flexibilities that are set to expire at the end of this month and at the end of 2025. And some of that can really heavily affect workflow depending on how your practice has taken on telehealth services. So, love if you would join us. Go ahead to my website, you'll see that. If you use the code TLH1010, so TLH10 at checkout, that'll give you 10% off. All right. We will see everybody next week.